This is a surgical technique video demonstrating how to perform an arthroscopic meniscal root repair. Meniscal root tears are defined as a tear within 1 centimeter of the root insertion. Recent literature has highlighted that they are more prevalent than previously thought, occurring in up to 20% of meniscal tears. Management options include surgical and non-surgical treatment. In elderly patients with advanced arthritis, non-operative treatment including activity modification, therapy, and injections is usually recommended. In patients with irreparable tissue, partial meniscectomy may be performed. Root repair is typically advised for active patients without any significant arthritis. The importance of meniscal root function has been evidenced in the literature as root tears result in altered joint biomechanics. Left untreated, these changes can lead to accelerated chondral wear with rapidly progressive arthritis. Further, a study found meniscal root tears in 78% of patients who underwent total knee replacement. Identification of root repair tears is, therefore, crucial to maintaining knee health. In fact, repair has been shown to restore joint loading characteristics. In this case, the patient presented as a 60-year-old female with progressive left knee pain and mechanical symptoms failing conservative management. Physical exam was notable for normal gait and alignment, decreased knee flexion, mild effusion, and medial joint line tenderness. She had a positive medial McMurray test with an otherwise ligamentously stable knee. Standard knee radiographs showed minimal medial joint space narrowing and no gross malalignment. MRI was obtained for further workup and demonstrated tearing of the posterior medial meniscal root with significant medial meniscal extrusion. Given her symptomatic presentation and imaging evidence of the root tear without any significant arthritis, she was indicated for arthroscopic repair of her meniscal tear. A transtibial pull-out technique was planned due to its biomechanical efficacy as evidenced in the literature. In cases of posterior medial root tears, it can be helpful to pie crust the deep MCL to open the medial compartment and avoid any iatrogenic chondral damage. Here we can see gradual opening of the medial compartment as the pie crusting is performed. Next, a healing bony bed is prepared with a ringed curette and shaver in combination located at the anatomic footprint of the posterior aspect of the medial meniscal root. It is critical to identify the anatomic footprint as biomechanical studies have shown placement even 5 millimeters outside the footprint may not appropriately restore joint loading. Viewing from the anterolateral portal, an aiming device is used through the anteromedial portal to create 2 small transosseous tibial tunnels. The first is placed on the posterior aspect of the footprint. The bullet is placed down to skin to mark the incision is made, and dissection is carried down directly onto the anteromedial aspect of the tibia. The bullet is then positioned down onto bone and a guide pin is placed. It is crucial to be performing direct visualization of this guide pin to avoid any posterior penetration of the soft tissue structures behind the knee. A second tunnel is then drilled with the assistance of an offset guide to appropriately reapproximate the anatomic footprint of the posterior root. A cannula is then inserted in the medial portal for suture management. A suture passer is utilized to place a suture through the peripheral aspect of the posterior root. A nitinol guide wire is then utilized through the anterior transosseous tunnel to shuttle this peripheral suture through the anterior tunnel. A second suture is placed more in the central aspect of the posterior root. A nitinol wire is again used to shuttle this central suture through the posterior tunnel. This will create a crossing configuration that maximizes surface contact area for later healing. The anterior and posterior sutures are then tied to each other over the osseous bridge between the tunnels under direct visualization with the arthroscope to confirm appropriate tensioning. The final construct is evaluated with the probe to confirm appropriate reduction and fixation of the tear. A standard post-operative meniscal repair protocol is prescribed as shown. Phase 1 starts with patellar mobilization and focuses on restoration of motion. Phase 2 transitions to strength and endurance training, including closed chain exercises. Phase 3 advances power development through agility exercises. A functional sports assessment is typically performed to determine readiness to return. Clinical research has demonstrated significantly improved post-operative outcomes for meniscal root repair. Importantly, multiple studies have shown root repair may slow the progression of arthritis. Further, these outcomes appear to be cost-effective relative to non-operative treatment and partial meniscectomy. Thank you for watching this video demonstration of meniscal root repair.